Hi, I'm Dr. Robert Clark. I'm a clinical associate professor of ophthalmology at the Stein Eye Institute, UCLA, and owner of South Bay Family Eye in Long Beach, California. I'm going to talk about low-dose atropine eye drops for myopia control in children. After the LAMP studies were published, atropine 0.05% is having a moment. A lot of clinicians use it as the default starting dose for children with myopia, replacing the previous favorite, atropine 0.01%. And the debate seems simple: 0.01% versus 0.05%. 0.05% is more potent and is well tolerated, so why waste time using the weaker concentration? But 0.05% is the answer to the wrong question. Ask the wrong question, get the wrong answer. Clinicians debate concentration when they should really be discussing formulation. Atropine eye drops don't just include atropine. They are a complex mixture of ingredients. And depending on the formulation, those ingredients can behave differently when administered onto the eye. Here's the right question. Which atropine formulation gives most children the best balance of safety, efficacy, and day-to-day tolerability, especially when they're using atropine for the very first time? Because the number on the label isn't necessarily the delivered dose. In real life, what reaches the target tissues depend on what's in the bottle. Why does formulation matter? The original studies were conducted using preserved eye drops. The landmark ATOM2 trial, the study that launched atropine 0.01% into widespread usage, used atropine 0.01% preserved with BAK in multi-use bottles. The landmark LAMP trial, the study that has promoted atropine 0.05% as superior to atropine 0.01%, used a preservative-free formulation in single-dose vials. Each formulation has important benefits. Preserved formulations are easier to store and usually less expensive to manufacture. Plus, preservatives like BAK can increase corneal permeability by disrupting the corneal epithelium, allowing more drug to enter the eye. Preservative-free formulations are usually more expensive to manufacture and involve single-use vials to prevent contamination, but are gentler on the surface of the eye. Without the preservative, however, penetration can be lower even if the concentration on the label is higher. There are other potential differences as well: pH, buffer, and inactive ingredients. But the two most important differences are preserved versus preservative-free. Here's the key point. Concentration has to be paired with formulation to determine how much atropine is actually delivered to the target tissues within the eye. The same labeled concentration can deliver a completely different dose because of differences in formulation. ATOM2 and LAMP highlight how formulation is as important as concentration. Comparisons between different studies are never as well controlled as comparisons within the same study. But these studies are very similar: Asian patients, fast progressing myopia, and the same treatment outcomes. The major difference is that ATOM2 and LAMP did not just test different atropine concentrations, they tested different formulations, preserved versus preservative-free. We don't have aqueous pharmacokinetics from these trials, but we do have clinically meaningful physiologic signals. Atropine has two predictable side effects: pupillary dilation and reduction in accommodation. Measuring those side effects are not the same as a pharmacokinetic assay, but they are objective pharmacodynamic fingerprint of how much atropine penetrated the cornea. After a 2-week wash-in period, LAMP preservative-free atropine 0.01% barely moved the needle, causing only 0.4 millimeter pupil dilation and 0.6 diopter decrease accommodation. Preservative-free 0.05% had a noticeably larger effect, with 1 millimeter pupil dilation and 2.2 diopter decrease in accommodation. After the same 2 weeks, the ATOM2 preserved atropine 0.01% caused 1.1 millimeter pupil dilation and 4.9 diopter decrease in accommodation. Atom 2 preserved 0.01% looks much closer to lamp preservative-free 0.05% than preservative-free 0.01%. That's the first clue. Corneal penetration of preserved 0.01% appears much higher than preservative-free 0.01%. Here comes the second clue, the one that matters the most. What were the respective 2-year outcomes? After 2 years of treatment, Atom 2 0.01% and LAP 0.05% landed almost the same place, 0.5 diopters of myoprogression and 0.4 millimeters of axial length growth. Both those results are far superior to LAMP 0.01% at 1.1 diopters of myoprogression and 0.6 millimeters of axial length growth. So, when people say 0.05% is clearly more effective than 0.01%, my response is, which 0.01%? Because preservative-free 0.01% and preserved 0.01% did not achieve the same delivered dose. The outcome data plus the early pharmacodynamic signals tell the same story. Atom 2 preserved 0.01% outperformed LAMP preservative-free 0.01% and behaved a lot like LAMP preservative-free 0.05%. To be clear, this is not a head-to-head trial comparison because baseline age and refraction were different. But when both pharmacodynamics and treatment outcomes converge in the same direction, it is a strong signal. Now let's address something even more important, the part that gets ignored when debating the optimum atropine concentration. Not every child will respond to atropine regardless of the concentration. Even at very high concentrations, up to 1%, there are atropine non-responders that continue to progress. That is not a failure of the drug. That's biology. Some eyes just keep growing fast even on maximum concentrations of atropine. What is the downside when we start high as the initial concentration? We increase side effects for everyone without magically converting every non-responder into a responder, which means we end up paying a high tolerability tax and still don't get the outcome we wanted. This is exactly why the starting strategy matters. The goal is not to find the maximum tolerable dose. The goal is to determine the minimum effective dose, the lowest dose that delivers meaningful control while letting children function normally without compromises like light sensitivity or blurred vision. LAMP demonstrated good tolerance to atropine 0.05% in its Hong Kong population. But similar tolerance is not guaranteed for different populations and different formulations. In non-Asian children, we now have multiple published studies reporting that 0.05% can be much harder to tolerate than 0.01%, with significantly more pupil dilation and blurred near vision from loss of accommodation. If children have light sensitivity and blurred vision, they are more likely to stop treatment. Tolerability isn't a side issue, it is a core issue, because strong adherence to treatment can improve real-world results. Finally, there's another big shift in myopia control that reframes this entire discussion. Until recently, we had only one FDA-approved treatment for myopia progression in the United States, the MiSight soft contact lens. Since many young kids can't handle contact lenses, off-label compounded atropine drops became the default treatment for myopia control, not because they were perfect, but because they were available. Now we moved into a new era of myopia control with an FDA-authorized spectacle lens option, the Essilor Stellus lens, that has no known side effects. Now the bar against drug side effects gets higher, and the case for start with a minimum effective dose gets even stronger. So where does that leave us? Here's the takeaway. If you're prescribing atropine for myopia control, don't think about 0.01% versus 0.05%. Start by asking, what formulation am I using? Preserved or preservative-free? How likely is the child to tolerate it? And what does the evidence suggest about the delivered dose, not just the labeled concentration on the bottle? For many US clinicians, the answer to those questions is preserved 0.01%, used consistently and monitored closely for efficacy. This video is not about being anti 0.05% or pro 0.01%. It is pro understanding the details behind the science and starting with the atropine formulation that most kids can tolerate and maintain. It is pro escalating the concentration only when the clinical data in that child provides a clear signal that escalation will be tolerated and is the best available treatment option. Here is the clinical take-home message. Number one, stop using atropine concentration as the decision point. Use concentration plus formulation. Number two, for most US children, the best balance of efficacy and tolerability is preserved 0.01%, not preserved 0.05%. Preserved 0.01% most closely resembles last preservative-free 0.05%, and it carries a much lower risk of light sensitivity and blurred near vision. And number three, expect to encounter non-responders. If the child is still progressing at 6 months, or especially 12 months, consider adding or switching to optical treatment, especially if you note some pupillary dilation on the atropine concentration that the child is already using. That is the current state of the art for low-dose atropine eye drops for myopia control. Start with the minimum effective dose. Match the treatment intensity to each child's response, and don't accept avoidable side effects. As a clinician, the final question you need to answer is, do you believe that LAMP preservative-free 0.05% is effective at slowing childhood myopia progression? If you do, you should also believe the results of the ATOM2 study, that preserved 0.01% is also effective at slowing myopia progression. Thanks for watching this video. If you have any questions, please leave them in the comments. Plus tell me what atropine formulation you're actually using, because that may be the most important variable in this whole discussion.